Welcome to this International Contrast Ultrasound Society Roundtable on Safety of Ultrasound Contrast Agents. I'm Richard Barr. I'm a private practice radiologist in Youngstown, Ohio. On the roundtable today, we're going to discuss the use of ultrasound contrast agents with a bunch of international experts in both radiology and cardiology. We're going to discuss what the safety of these agents is compared to CT and MR, how we should be prepared if there is a reaction, and a lot on the risk-benefit and why we have such a high risk-benefit that despite the rare incidences of severe adverse events, these agents should be administered quite frequently, much more than what they presently are used. So let's start with Dr. Cleaver.
Hi, I'm Dirk. I'm a radiologist from Munich, Germany, and I do ultrasound since more than 20 years, started with my first examination in 2000 until now.
Dr. Wilson.
I'm Stephanie Wilson. I'm a radiologist from Calgary in Canada, and I run a very large ultrasound facility that does really only contrast-enhanced ultrasound. And I've been involved with this since the year 2000, and our group were instrumental in obtaining the approval for microbubble contrast agents for use in radiology in 2002. And so since that time, it's been my passion. We do it daily and run a very large, very successful facility.
Dr. Porter.
I'm Thomas Porter, a cardiologist at the University of Nebraska Medical Center, and I've been using ultrasound contrast agents since 1990, prior to their FDA approval and up to the present.
Dr. Casa.
My name is Casa Darghi. I'm a pediatric radiologist, and I am currently the radiologist in chief and chair at the Children's Hospital of Philadelphia at the University of Pennsylvania in Philadelphia. And I have been using contrast agents in children since early 90s, so over 30 years. In 2013, we established a Center for Pediatric Contrast Ultrasound at the Children's Hospital of Philadelphia, where we do different contrast ultrasound studies in children.
Dr. Strom.
Hello, my name is Jordan Strom. I am a cardiologist based in Beth Israel Deaconess Medical Center in Boston, Massachusetts, and direct the Echo Lab where we do a high volume of contrast studies. I'm probably the youngest one of the group. I've been doing this for about 10 years now in practice.
And again, I said I'm Richard Barr. We've been doing ultrasound contrast since the late 1990s, and we've actually done most of the FDA trials and all of the agents. So again, we've been doing this for over 25 years. So if we look at our panelists, you can see that we have over 100 years experience in the use of ultrasound contrast agents, a large volume. So we look forward to our discussion of what our reactions are that we're seeing in safety in these agents as we go through this roundtable discussion. So I'm going to start by asking Dr. Porter just to give an overview of ultrasound contrast agents. What are they? How do we administer them? And what are we using them for?
Well, we use them, they've been around, as we've seen by the different panelists here, for quite a long time. The FDA has approved ultrasound enhancing agents in the United States in 1998, and subsequently there's been 2 more approved. But they're pretty much synonymously with the microbubble. They're basically an encapsulated gas that allows us to see and enhance the endocardial border, which is what their FDA-approved indication was initially. And it's been used for many more applications by clinicians throughout the world. You're aware, obviously, of the radiology applications, and you'll discuss those, but from the cardiology perspective, they've been used for enhancing left ventricular opacification at many major universities and private centers. And they've been utilized to enhance Doppler signals and look at myocardial perfusion and analyze myocardial blood flow. So their applications have expanded, although they're just approved for enhancing endocardial border. They've had multiple applications that have really changed the scope of cardiology from having to revert to other imaging techniques to get good pictures to getting beautiful pictures on very difficult patients. with the use of the ultrasound enhancing agent.
Dr. Wilson, he gave a nice overview of the use in cardiology. Can you give us an overview of where you're finding is very useful in radiology?
Yes, a very, very different application. And so when we inject the microbubble contrast agents, they enhance the Doppler signal that comes from the blood. And so prior to the introduction of these contrast agents for radiology, if patients had tumors or masses anywhere in their body, they really had to have a contrast-enhanced CT or MR scan to show the differential in the tissue perfusion that allows for diagnosis of tumors. And I'm only selecting one indication. But so when we were allowed to have microbubble contrast agents for radiology applications, this allowed us for the first time to show vascularity within organs and within tumors right to the perfusion level. And so this allowed ultrasound with microbubbles to be competitive with contrast-enhanced CT and MR scan for looking at tumors and organ perfusion throughout the body.
So right now, the only FDA approval for adults is liver, but off-label use is used quite a lot. I use it almost every day doing renal cases. Do you find off-label use in other organs being helpful, or?
Yes. So originally we had to get a Health Canada approval each time we went to a new organ, but that quickly came to an end because we would have inundated them with requests. And so now every time I see a patient where I think to myself, would blood flow information help us in the interpretation of what's wrong with this patient? And so then we extend our use. So now we do it routinely for looking at all of the solid organs in the abdomen. We look at ovaries and ovarian cancer, all of the pelvic organs, and then in addition we've expanded to look also at the bowel, where the use of the contrast agents, we're not usually looking for tumors, but there the blood flow reflects the inflammatory activity, so it allows us to determine how sick the patient is because of their inflammation, and it also allows us to show their response to therapy, recognizing that the very first response occurs at the perfusion level. So
Great, and you know, one of the things that we have found was that we have very thin slices. They're sub-millimeter slices compared to usually 2.5 millimeters for MR and CT. So for me, looking for small nodules in cystic renal cell carcinomas, we routinely see these 1 millimeter enhancing nodules that we cannot see in CT and MR because they're volume averaged. And also, we have very high frame rates. And we can look at over a long period of time. And again, for us, we see that the response of enhancing and washout is very much better visualized because we have that high frame rate. And on CT and MR, we often miss key information based on the timing. And let me ask Dr. Darga about not intravenous use, but intravesicular use in pediatrics.
So one of the first uses in children was the intravesical application of the contrast agent for detection of vesicoureteric reflux. The conventional study for this pathology has been fluoroscopic study, but with the administration of the contrast agents, we were able to detect more reflux and all the details of the urethra also, so that this examination has been increasingly replacing the fluoroscopic study. And in addition to having higher diagnostic accuracy, the contrast agents also provided an examination environment that allows the parents to be around the children, and also the children to void in more physiologic way than when we were using fluoroscopic studies. So that has been the first indication that spread among pediatric radiologists, especially in Europe. And then when it was approved in 2016 in the US, the FDA approved it also for use for detection of vesicoureteral reflux. And that has allowed many centers to use this modality for detection of reflux in children, replacing in many places the fluoroscopic study.
So Dr. Strom, you've done a lot of work on adverse events in these agents. Can you just summarize what type of adverse events we can see? And we'll later on discuss incidents of that, but can you just kind of give us an overview of what we can maybe expect? Not basically, they're basically the same as on CT and MR and all contrast agents, but a broad overview of the type of reactions we can see.
Yeah. So the vast majority of patients, I think it should be said, don't have any reaction. We do have mild reactions are common. Those things include things like hives, some itchiness or pruritus. Sometimes people feel flushed or might feel nauseous or have other symptoms related to that. But in general, those symptoms are fleeting and transient right after the administration of the contrast agent. Rarely serious reactions can occur, the most common of which is a CARPA reaction, a so-called complement activation-related pseudoallergy, felt to be sort of from overactivation of the immune system with the injection to the contrast, and that can present very much similar to an anaphylactic reaction. It can be associated with low blood pressure. It can be associated with abdominal pain or discomfort, hives, or diffuse rash and flushing, and at times can be life-threatening. This is extremely uncommon, and again, I think we'll talk a little bit more about the incidence of these later, but importantly, can occur on somebody's first receipt of an agent. So it doesn't require, unlike a typical type 1 hypersensitivity reaction, it doesn't require prior exposure to the agent for people to be able to get it. Back pain is a frequent but mild common side effect that people can have as part of the agents, may be felt to be in part due to retention of the microbubbles in the glomerular capillary bed, but ultimately can cause some discomfort for some period of time after the study and ultimately is transient and goes away shortly thereafter. And then what we've been recently encountering, unfortunately, more of is a Kuhn syndrome, which is an allergic coronary either constriction or basically allergic acute coronary syndrome that can happen as a result of a reaction to any kind of contrast medium. It has been described in other contrast media outside of just ultrasound contrast, but it has also been described with ultrasound contrast as well.
So let's go around the panel and ask how many exams do you do? How often do you see reactions? And I'm going to ask Dirk to also give us an overview of the European as well as Chinese radiology data.
So recently I just looked up how much examination I've done, and it's around about 11,000 examinations starting from 2000 up to 2023. In this 11,000 examination, only in our center in Munich, we have seen 16 reactions. Most of them was mild, only one severe reaction. And this confirms also the findings if you look, for example, for the Italian study, which looked for a time period of 3 years, and they include 23,000 examinations, and the risk was 0.1. And if you ask me, does it change over time? So the Italian group, that was more than 25 centers, repeat this examination or this study 20 years later, and they get the same number of patients and nearly the same results. And does other center or does other countries have similar results? There was also a big study from China which included more than 40,000 patients, a huge amount of data, and the risk in this study was even a little bit less in comparison to my personal and to the Italian groups.
So Dr. Wilson, you've been doing this a long time in radiology and not only doing livers and kidneys, but a lot of different organs. Can you tell us your experience in terms of reactions to the contrast agent?
So our department does contrast-enhanced ultrasound every day, all day long. So we've done, since about 2010, we've done 25,000 patients. And some of those patients are repeat patients who come back several times. And we've had a very successful run at this in that we have had no significant adverse event. And in fact, we've had very few patients even show hives or allergy. And the one thing that we do encounter, not frequently, but perhaps maybe less than one a month, would be a patient who gets colicky back pain. And this is transient, and we find that with immediate reassurance to the patient that there's nothing that's seriously wrong with them, that this is going to go away, that we're aware of this, and that it will respond in a minute or so, they'll be feeling perfectly well. That patients love that reassurance. I think that they don't have anything seriously happening to them. And so we have really virtually nothing that has ever happened in our department.
So keeping with radiology, Dr. Darga, can you tell us your experience in pediatric patients?
Yes, as I've mentioned before, I've been doing contrast ultrasound since the early 90s. Initially, it was primarily the intravesical application, and then later on the intravenous applications. Especially after the FDA approval, we at the Children's Hospital of Philadelphia, through the Center for Pediatric Contrast Ultrasound, have been pushing for the use of contrast agents. So we've done since we started at CHOP since 2013 using contrast ultrasound here in the US, and this at this time it's somewhere over 3,000 patients, pediatric patients, and for pediatric patients that's a humongous number. Probably we're the largest center using contrast agents in children. But I just want to point out that we have expanded the use of contrast agents in children significantly in terms of the off-label use. So we use intravenous contrast literally for every organ from head to toe, and from preterm to young adults. Plus, we use contrast agents in the intracavitary, the intravesical form. However, we also have expanded its use in the interventional use in various different forms, and also now expanded its intralymphatic use in children. So we have a variety of uses, and over this time, it's almost over 10 years, we had one adverse event with the intravenous application of the contrast agent. The patient had anaphylactoid reactions. We responded promptly and then sent the patient to the ED, and the patient was observed and treated there and left the hospital without further complications. So, and this was the only patient I have encountered in my practice over 30 years. That doesn't mean this is not happening, but the data in children comprising about 5,000 examination has shown that the rate of severe adverse events is around 0.2%. So in the 5,000, about 10 children had anaphylactoid type of reaction or serious adverse event that were all treated and recovered. The intravesical application is much more in use, and there are data that's almost nearing 15,000 patients, and there are no serious adverse events. There are minor events. All these are less than 1%, and usually because you need to put a catheter into the bladder in order to administer the contrast agent, the non-serious adverse events are related to the use of catheter rather than the contrast agents. And one last point I want to add, we recently published jointly together with Johns Hopkins Hospital, the Children's Hospital, data regarding the administration of contrast agent intravenously in ICU patients, specifically ICU patients in pediatric ICUs, in newborn ICUs, in cardiac ICUs. We put that data together to see, because these are patients on ECMO, multiple medications, severely sick, who had been given ultrasound contrast agents. And in this group, in this study, joint study of two institutions, there were no serious adverse events with the administration of contrast agents in, sick patients in the ICU, in the newborn or in the pediatric patients. So this has already now been published.
Great. So let's switch now to cardiology. And Dr. Porter, you want to give us your experience? Obviously, the agents have been used for a longer period of time and at a greater extent in cardiology than they have in radiology.
Yes, sir. So the first safety data we published was back in 2005, when there was two agents available, and had repeated all of that again. We've been yearly monitoring that for example, in the last 4 years, pre-COVID and post-COVID, we've been doing about 10 to 15,000 studies a year. We also, Casa mentioned, do off-label applications like myocardial perfusion imaging. So all of our stress echoes get ultrasound enhancing agents, and then up to 60% of our inpatient population gets ultrasound enhancing agents with their studies. And they provide a tremendous amount of benefit, but we have looked to see what the event rates, the serious adverse event rates that would require either epinephrine or volume resuscitation. And from 2020 to 2019 to 2023 to 2024, that rate has stayed constantly at 0.1%. So it continues to be very similar to what you described in Munich, and what Casa describes in his patient population, a very, very low percentage of serious adverse event rates.
And Dr. Strom, you do a lot, and you've also looked at the literature a lot. You want to give us an overview of your experience as well as kind of the literature in cardiology?
Sure. So at our center, we have a very busy echo lab. We do about 25,000 transthoracic echoes to about 30,000 transthoracic echoes per year. And about 40 to 50% of those do receive ultrasound contrast. We have had, we've used all of the commercially available agents historically, and have had an excellent safety record over the course of 20 plus years of use, with rates overall sort of similar to those that were mentioned across the board. We have had a case recently where we had a patient with underlying Kunis syndrome. This was a gentleman who had received a stent and otherwise was stable, received the contrast agent, had flushing, hives, and ultimately had ST elevations and chest of discomfort, was taken to the cath lab emergently and was found to have a spasmed right coronary artery at the time that wasn't previously spasmed on the prior catheterization. So suggestive of this being underlying Kunis syndrome. The patient ultimately did well, that resolved, and the patient has no sort of ill effect from that. But it is an ongoing question, and we in general have seen through the FDA safety report data set, the adverse event reporting data set, that non-CARPA reactions occur in about a rate of less than 1 in 20,000. So they're very infrequent. CARPA reactions, we know from prior literature, extensive literature within the cardiology sphere, occur in about 1 in 15,000 cases, and there are, like I said, an enormous number of patients that have been included in several different safety studies over the course of 20 to 30 years of practice that have suggested that the safety event rate is fairly low, is around 1 in 15,000. The largest one of those studies is a study by Dr. Michael Main, where they enrolled about 4 million patients in the premier data set. Who had received contrast. Contrast was used in patients at around 1.4% of cases, and adjusting for case mix and those kind of likelihood of people receiving contrast, patients receiving contrast were actually less likely to die within 24 hours after the study than patients who didn't receive contrast. And that actually is echoed by contemporary data that we now have that's currently in press, where we've looked at all payer claims across the United States, hundreds of thousands of patients, and have also similarly identified that in contemporary practice, those who receive contrast were actually less likely to die within 24 to 48 hours.
So I usually mostly use off-label use, and we've done about 7,000 cases, and we've had one serious adverse event. But I've recently looked at the literature. There were 118 radiology publications, most of which were actually prospective, looking at a little bit over 600,000 patients receiving contrast agents in radiology. And of those, minor AEs occurred in 376, which is 0.062%, and serious adverse events occurred in 22, which is 0.004%, and there were no deaths. So the results seem to be very uniform across the world versus radiology and cardiology, and we'll talk about some little differences later on between cardiology and radiology. Can I ask each of you how you prepare for the event if you do have an adverse event? And PEG came up as something that may be a problem. Do you ask patients if they have a PEG allergy or other allergies before you do injections? Dr. Cleaver?
Yeah, of course. First of all, I've given all patients some paper they have to read. I describe everything on this paper. These are 3 pages. They have got around about 1 hour before we start the examination to read. I ask them, additionally, do you need any more information, some side effect? Because they have to give an informed consent, a written informed consent in our department. I don't ask especially about PEG because this is not included in this paper, but maybe you have to think about for the future. But the problem is you never know when a side effect happens. It could happen twice a day if it's a very bad day, but sometimes 2 years nothing happens. So you have to prepare that something could happen. And in case an emergency happens, you have to know exactly where are the drugs you have to use. And the most times they expire before you use them. So you have to also get new drugs every year. But it's a good move to know exactly where are the drugs and where are the emergency call number, which if the problem you could not handle, that you could call, get some help.
Dr. Wilson?
Very similar, but I will comment on one thing. So in Canada, up till about, I think, 2015, we had to have written informed consent, as you do still. And prior to the discontinuing that practice for contrast ultrasound, the practice had long been discontinued for contrast-enhanced CT and MR scan. So if you consider that all those patients that have CT and MR scans every day do so with only provision of verbal consent, it became quite obvious to our hospital administrators that our massive amounts of paper we were accumulating by signing all these consent forms was not beneficial. So now we do practice informed verbal consent, and more so, for example, if we do pregnant patients where there might be more open contention about the fact that we do those scans. But so we inform the patients. I do always reassure the patient that I do not expect them to have anything happen, that I think this will be pain-free, event-free, and that the scan will be successful. But we do have them provide that consent. We have got nurses in attendance for much of our days now, which we previously did not have, only sonographers and the supervising physician. But now we often do have nurses. And we have always an ambu bag. We have oxygen on the wall of all of our examination rooms, and we have a crash cart, which we do the same as what you say. Obviously, they have to be refreshed because we don't use them. So all of the drugs that are in there expire and go to the garbage without ever being used. And then, of course, knowing the number and how to call for more help is an essential component of this.
Dr. Porter?
Well, first of all, we make sure that all of our sonographers and nurses now, all of whom can give contrast, we're very thankful for that, are aware of the benefits of ultrasound enhancing agents, because we're always taking on new sonographers and new nurses, and so everyone kind of gets a training on all the benefits that we see with ultrasound enhancing agents. Then we explain to them there's that very small risk that we all just outlined of the possibility of an adverse reaction. So all of our sonographers and nurses have basic life support training and know how to give subacute epi should that be necessary in the case of a serious adverse reaction. So that training exists, and there's a physician available usually within a certain distance whenever we're giving ultrasound enhancing agents in our echo labs. Our clinics are right next door. So there is always one at least physician available should there be any need for that.
Dr. Darga, you have a special population. Is there anything special that you do other than what we do in the adult population?
Not majorly special, but we have to remember also the reactions and the issues that you raise are also usually percentage-wise even less in the pediatric populations. And half of the population we use is intravesical use, and that has been shown over 30 years to have no really major adverse events, and we are really not concerned with the intravesical administration and having any kind of reactions. And that is we have specialized technologists from fluoroscopy place the catheter, and our sonographers inject the contrast intravesically and do the studies. The intravenous ones in our practice, the IV line are usually placed by our nurses. We have a screening form for the ultrasound contrast agents like we have for CT and MR, and do the same kind of screening. We don't do written informed consent. This is off-label use. And as you know, many of the contrast agents and other drugs in children are more off-label than on-label anyway. So the practice is to use these off-label without any kind of informed consent. We don't have all the time the nurses unless the patient is as an inpatient, and when it's inpatient we call the nurses and to help us inject the contrast. What we have done is something with the introduction of the contrast enhanced ultrasound studies is to have a dedicated code card in the ultrasound suite, which we didn't have before because we didn't use contrast before. So we have a dedicated code card. We trained the doctors and the sonographers how to use the code card. We had simulations, and we try to do these trainings on a regular basis. But as mentioned by my colleagues, it's so rare, the reactions, that you really forget that you have these things. And also the drugs expire also, so you have to have constantly renew these, replenish the drugs in these code cards. Outside that, we don't have any other special arrangements that we do specifically for the pediatric patients.
Dr. Strom?
Yeah, I agree with Dr. Porter here. We really focused on the benefit up front, and in cardiology we take on a lot of risks, and the question is really the risk-benefit ratio. And in this case, we really want to make sure our sonographers understand what they're doing for the patients and the benefits of imaging. Understanding as well that in general, compared to other types of contrast media, ultrasound contrast agents are amongst the safest as a whole. That being said, there is this small fixed rate of severe adverse reactions, and we have a very extensive safety program with our sonographers. Our sonographers do inject ultrasound contrast themselves, and so as a result, we set up a program where they get training on an annual basis and re-credentialing. We have them take a test on sort of understanding the indications for use of contrast, but also to understand how to respond in the case of an emergent event. We have in all places that we do imaging something on the wall that sort of tells people where to, what numbers to call, and we actually have it as a sort of flip card now on the actual machines themselves as people are traveling portably. We have a system in place where there's a bubble pager. The fellows at our institution carry out the bubble pager, and if there is ever an event or even a concern for an event, we tell the sonographers to call, page the bubble pager, and we tell our fellows that this is like an ST elevation MI. It's an emergent case. You drop everything and run to help the sonographers, because we don't want the sonographers to be suffering in sort of silence here. And so That's worked incredibly well. We have a separate allergy kit. We have a code cart, but we also have a separate allergy kit. I think it's important to note that the typical code cart has epinephrine at a dose of 1 in 1,000 versus an EpiPen, which has a dose of 1 in 10,000. So it's a whole different concentration. The typical code cart doesn't have things like an IV start kit, infusion, tubing, or pressure bags for saline, for instance. So we have all that within our allergy kit. We also have things like antihistamines that we sometimes use, particularly for sort of milder forms of reactions. And we keep that readily stocked. We do verbal consent with our patients. We do ask them if they've ever had a problem with any bowel preps, getting to the issue of prior PEG exposure or PEG allergy. I have to say it's never come up where that's been the case, but we do ask the question. And the couple of situations where we have had events occur or concerns about events occur, things have worked very smoothly. People responded right away, and the patients overall do well. And this is something we've considered when we start up new practices and new labs. So, for example, we expanded to an outside clinic in Lexington, and before we even started the use of contrast in that setting, we wanted to make sure who was available to be able to respond, what was the chain of command for that person to be able to respond to an event, and in those circumstances where the person may be absent or away on vacation or gone, who else is there in their stead? And we wanted to make sure all of those bones were in place before we ultimately started use of contrast. And it's gone fairly well in those circumstances as well. So maybe perhaps we are very, very, very prepared, but I think in a couple of circumstances where we have had to use it, it's really an important system. The other thing we do is with our sonographers, if there is an event, is debrief afterwards. I think it's a really important opportunity to address what happened in the room, what went well, what didn't go well, what can we learn from our future interactions. But all our sonographers now have sufficient experience with it. They're very comfortable administering contrast, and we really have a very robust safety program in place.
So I'm kind of unique. We are an outpatient facility that is not attached to a hospital. We do not get written informed consent. We've been doing oral informed consent for many, many years now. We do ask if the patient has allergies. We don't particularly ask them if they have PEG allergies, but we are aware that that could be something, and if they mention that they have an allergy to something that may contain PEG, we're a little bit concerned about that. Because we're a small center and we do CT, MR, and ultrasound, we have one crash cart that's for all modalities, and it's readily available, and we have nurses there. We must have a physician present before we inject any contrast agent, be it CT, MR, or ultrasound. So there's always a physician with CPR training. The American College of Radiology has a very nice sheet that describes reactions and how you should treat them. That's readily available. And we actually see many more reactions from MR and CT. So most of our practice of dealing with these reactions is from MR and CT because it's so rare in our practice to see it for ultrasound contrast. But we do have nurses available, again, we're not attached to a hospital, so if we do have somebody that we start to resuscitate and we're having problems, we call 911, and we have a hospital that's a mile or two away, that the ambulance will come pick up the patient and bring him. That occurs maybe once or twice a year, and it's never happened with ultrasound contrast, but it's happened several times with MR contrast that we've had to send the patient to the emergency room for treatment. So we talked about reactions, and we say that they're really minimal. Severe reactions are quite low. One thing that we'll discuss a little bit more is a severe reaction that really is deaths. We'll talk about that a little bit more because there seems to be some discrepancy between modalities or cardiology versus radiology, the world versus the United States. So we'll talk about that a little bit more. But one of the key things about this is risk-benefit. And can you describe what you consider risk-benefit? What patients do you give this to and you realize that there is a small chance of a reaction, but it's going to benefit the patient. So for example, we've been asked to do pregnant patients, and for me, I have the referring physician write a note when he writes the prescription for us to do the exam that we've discussed the risk-benefit, and we feel that the benefit outweighs the risks in the pregnant patient, and the patient consents to that. So, those are things that we do in those special situations where maybe it's a patient that normally would not get contrast. The vast majority of our patients are patients that have renal failure or some problem where they can't get CT or MR contrast. And one of the things that we do is many of these patients, particularly the renal failure patients, are very concerned that we're going to influence their renal failure by doing this. So we allow them to know that, yes, this agent is going to be injected, but it has no effect at all on renal or liver function, and this is the only safe agent you have. And I think many of our patients are very grateful because many of them have masses that can't be characterized without contrast. And they get this, well, we don't know what to do from CT and MR, but we're able to answer the question. And again, many of those cases are benign cases, and we can clearly say that they're benign. There's no enhancement of the lesion. And we actually get patients from around the United States by Googling us. And we had one patient that sticks out that came from Florida, that she had a renal mass. She couldn't get CT or MR contrast. They did a nephrectomy on her, and it was a benign cyst. She then went into renal failure. And now she has a new mass on the other kidney, and she came to us, and again, we injected her, and it was a benign cyst. But basically, the risk-benefit for her would have been if she would have had an ultrasound contrast, she would not have had a nephrectomy and gone into renal failure. So this is not an uncommon situation that we see, and maybe you guys can give us your experience of the risk-benefit and where you see that we really make a big impact by giving ultrasound contrast.
Yeah, I think you have to really point out the fact that there's a lot of patient education that's necessary as much as sonographer education. Our physicians order use contrast if necessary. So that leaves the echo lab with the ability to use that when they feel it's necessary, and then it's very important that the patient and physician and sonographer know that you're going to do much more harm maybe by not giving contrast than giving contrast. So that's why that education part is so important, to let them know that we're going to learn about perfusion. We're going to see regional wall motion abnormalities that we would not have seen if we didn't use contrast. And several of our sonographers have been surprised by patients they're doing chest pain evaluations on or shortness of breath evaluations on, where they were going to call the ejection fraction normal and regional wall motion normal, and then they give the ultrasound enhancing agent and they see wall motion abnormalities that they would not have detected that were due to acute coronary syndromes. So there's a lot of benefit there, and that's important to stress to the patient as well as to the sonographer and all those involved with the patient care.
So we're talking about 1 in 20,000 having a reaction. Would you say that you're changing your diagnosis in a lot less than 1 in 20,000?
Yes.
So really the risk benefit is quite good, and I think the paper by Maine pointed out that survival giving contrast in cardiac cases actually improved outcome as opposed to not giving it.
Jordy, I think you had some additional data on that, right? You found very similar results with your group.
That's right. So 20 years later, different practice, right in the context of COVID and everything else going on, we have an almost identical signal with a reduction in mortality in the sort of early time period right after a given contrast. And I think that you see so much to add to that. The regional wall motion abnormalities that we see, we've had sonographers who have identified thrombi, potential stroke avoided in a patient who otherwise wouldn't have been able to identify or see the apex. About 10 to 20% of our studies have really suboptimal image quality, and so it does become a really essential part of the diagnosis. And
Stephanie and Dirk, you both have been using this in pregnant patients and have published on that, and I think this is a really important population because they get diseases when they're pregnant, and obviously radiation from CT is a no-go. In contrast, either on CT or MR is a no-go. So I think we realize that the ultrasound contrast agents are safe in pregnancy, and I often get this, that the patient's breastfeeding, and should they not get the contrast agent because, again, there's concern that the other agents will be in the breast milk, and I think we're pretty confident that it's not, and I think the guidelines were wait 2 hours after the injection, and then it's safe for the mother to go ahead and breastfeed. But can you give us your experience on the patients that you've had that, again, would not have had good care if they did not receive the ultrasound contrast agents?
Yeah. So the first pregnant woman I include for examination was in 2005. It's around about 20 years ago. And this woman had got a huge hemangioma, but she had only MRI without contrast, so they was not sure what kind of lesion it is, and this lesion was 8 centimeters in the middle of the liver. So I do the examination, it's a hemangioma, no treat, okay, that's fine, she delivered fine, examination was perfect. My personal experience, if you show the woman before you start the examination the baby, that the baby is fine, moves fine, the woman will feel more comfortable. And if we are ready after the examination, the last image should be also image of the baby. Unfortunately, I also have learned that pregnancy doesn't protect from cancer. So we have even young women, less than 30 years, pregnancy, rectal cancer, get an MRI, without contrast, find 2 liver lesions. One on the right liver lobe, one on the left liver lobe. Suspicion of 2 liver mets. This may have a major influence on treatment. So this woman was also sent to us to confirm that she has got 2 liver mets. But we do with contrast, of course we give it a little more time to think about. But finally we found out one was a hemangioma and the other was a liver mets. And this has got a major influence on treatment. I mean, was very lucky that I can say it's even a horrible information if you say you have got 1 liver met, but it's better to have only 1 in comparison to 2 in different liver lobes. And MRI was not able to say this are hemangioma and this is a liver met because they have no contrast agents. Often we find very strange reports. That could be liver met, necrotic tumor, hydrated cyst, and abscess. So you can flip a coin because all of false diagnoses have complete different pathway of treatment. And if you can now make a correct diagnosis, this has got a major impact how to treat this patient. And also, the contrast will never pass the placenta, so the baby have no uptake. This is also very important information.
And again, that goes to these bubbles are somewhat large, so they don't extravasate like CT and MR contrast agents, which is again one of the advantages to these ultrasound contrast agents, because they don't leak out into the tissues. And again, that's an important thing that Stephanie has written a lot about, that in cholangiocarcinomas, the MR CT is exactly opposite of what we see with ultrasound contrast, because they have pseudo enhancement, where in ultrasound they have brisk washout, which again makes the diagnosis and saves the patient a lot of aggravation and worrying about what's going on because you can't make the correct diagnosis. So Stephanie, you want to give us your experience of benefits in some of your patients?
I'll just carry on with what Dirk said, just for maybe one case. When we do ultrasound scans in my department, it's my preference always that we're not looking at a gallbladder, we're not looking at a spleen, we're looking at the abdomen and the whole patient. And so many clinicians comment upon that because we find things that are not related to what they ask so often. But so for example, we had a young 32-year-old lady come pregnant, and she had inflammatory bowel disease, so she's part of our pregnancy IBD maintenance clinic. And so she comes for assessment of her IBD. So my sonographer does the scan and comes to me and says, the baby looks fine, the bowel looks fine. And then I thought, there must be something more to this, the way she's presenting this. And I said, but what else? And she says, well, she's got a big mass in her kidney, 32 years old. So we did a contrast, explained to her and to her husband, did the contrast, and this is a large, clearly renal cell carcinoma. And so the patient is referred to urology, and intrapartum, they remove this kidney. And so the urologist comments to me afterwards that usually those patients would have had both CT and MR scan, and that this patient had neither, but she had an intrapartum removal of her kidney with that large tumor, completely successful with no adverse event. And so this is how I believe we promote what we do as being a safe and beneficial technique. And when clinicians go to their grand rounds and showcases that you've given to them, and he says not only that, this wasn't even ordered as a pregnancy ultrasound, it was ordered as a IBD follow-up, but of course we do everything. But I think that when we look at the whole microbubble history, for us in radiology, it has been a bit of a slow uphill battle related to the fact that CT and MR scan were such established techniques at the point where we started. And then, of course, the FDA lagged for so many, not just years, decades, before they approved a microbubble for radiology. And so I think that in each instance, we have to go to an organ system and then show what are the benefits, like why are you doing this here? And I always remember our very famous patient in Toronto, I think Christine introduced me to him, and he came from an executive medical where they found a liver mass. And so when I came in the room for Christine to introduce me, he says, my first question to you is, why am I having this cheap test anyways? And so Christine says to him, probably you've just said that to the wrong person. So we, of course, solve all the problems that were unresolved on his prior CT and MR scan. And so the patient, when he left, of course, kudos and congratulations and apologies for his disgusting behavior. But it's a battle that I believe we fight to convince patients that they should come, what's the benefit of our examination, and to convince clinicians that this is the proper place to refer their patients. And so I do think that in each and every arena that we've gone into, we have successfully shown what's the added benefit. And Richard, you just touched on that. So the different behavior of the contrast agents between CT and MR and ICUS is one of the things that plays into our hand. We will always do a better job in any tumors that have that as a factor. And you touched on, Richard, the narrow scan plane and the high resolution that we have. And so this is beneficial. You proved it in your publications on the kidney, and we have there as well. But now when we're looking at ovarian cancers as well, we can see very, very incredible sensitivity to show the components of the masses that make them have malignant features. And so I think that, that this is a constant challenge to cardiology and to radiology to always make patients benefit aware of what we do. And of course, this does not take too long. Patients that come, they go back to their clinicians, we're aware of this, and they'll say, I quite prefer going to ultrasound with Dr. Wilson than having those MR scans. They're not comfortable and they're not fun. But so I think that those are great things for us, is that we can show the benefits that we allow.
So, Dr. Dargy, you have the most at-risk population. Obviously, would like to not radiate children with CT, and sedation is also another issue, because on letting children, you're having to sedate these patients to be able to do a good exam at CT and MR, where ultrasound, I think you can usually get away without having to do sedation, and even do the exam in a young child that maybe the mother's holding to comfort the child. So can you kind of give us the experience at CHOP?
Yes. So when we started early on with contrast ultrasound in children, the main discussion was always reducing radiation. And certainly that's still an important point. If you can do an exam without having to use fluoroscopic or CT radiation, it's important. And certainly that plays an important role in using contrast enhanced ultrasound in children. However, we have to think even beyond that, and I feel that very strongly now. One of the major impact in pediatrics is one, the significant improvement of workflow in pediatric patients, the reduction of sedation and anesthesia. I can't stress enough how much demand it is on the patient, on the department, and on the staff having to do examinations with sedation and anesthesia in children. This is a major drawback in imaging in children. And if we can avoid that, that is a significant impact in pediatric imaging, and contrast-enhanced ultrasound has helped us in doing that. That means you can do for a lesion in the liver an MRI or CT, but if you replace that with the ultrasound and the patient doesn't have to go to MR or CT, which is more expensive, takes longer time to schedule, is more cumbersome in arranging for the patient, especially if they are small, they need the sedation or anesthesia, then you have really made a significant positive impact on the patient and the families. And studies have shown that even on average, just using it on a regular basis, on IV use, over 50% of the studies you can use it and prevent doing an MR or CT in these children. And with increasing experience, you will be avoiding more and more CT and MR. Besides the sedation and anesthesia, we have also to remember especially the impact of the contrast agents themselves on the pediatric population. The gadolinium, as you know, is accumulating in different parts of the body in children. We don't know what that will be in the future. So avoiding such contrast agents is very helpful also. So the risk-benefit in children really the benefit outweighs multiple times than the rare occurrence of contrast agent reactions. So I think we really have to keep in mind what the impact contrast-enhanced ultrasound has made for pediatric patients, especially, as I mentioned, you can really broaden the prospect of how you can impact children using contrast ultrasound when you apply it, like I said, intravesical, interventional, intralymphatic, intravenous, and make a big difference. And also there are newer applications that are coming up, and then you'll understand why we didn't use anything before, now we use, and we can really improve the management of some of these patients. So I think contrast ultrasound for pediatrics, the positive impact is so significant that I feel it is ethically important, and it is our responsibility as pediatric imagers to share knowledge and to try to advance this modality and make it widespread in the pediatrics.
So one thing you mentioned before was that you can do this in intensive care unit.
Oh.
So I would assume having a pediatric patient in an incubator to bring down to MR would be a nightmare. Yeah. We're going up with the machine to the room, and then for us in radiology, it's the same thing. For us to go and do a case, and somebody that's got on a respirator and IVs, it's much easier for us to go than to have 2 or 3 nurses coming down and a respiratory therapist to try to get the patient in the MR. And the vast majority of the time, an ultrasound contrast will answer the question, and that there's no need to torture the patient and the staff to have them go through bringing this patient down to a room.
Yeah.
And one other question I have for you: what about the parents? How do they accept the use of ultrasound contrast?
Yeah, I mean, there have been some studies comparing, and the family experience is significantly positive. Why is that positive? One, the whole ultrasound exam is much more family friendly, with the parents being there, holding the child and doing the examination. The patient is not away in an MR scanner or in a fluoroscopy suite where the parents have to be far off. So the experience has been significantly positive for the families. In addition, of course, you avoid radiation, you avoid sedation and anesthesia, and you know there may be a potential impact of, for instance, anesthesia on the brain and things like that, and the contrast agent accumulating. So all that are really positive for parents. So parents actually Google these things and come up and want to fly from different places to come to have these studies done. So that's one of the reasons also it's important to spread the use of contrast ultrasound in children to avoid from parents having to go far distances to get these studies. To the other point that you mentioned, I mean, the bedside use has been really a positive addition, and as I mentioned, one of the important impacts is the workflow. And the workflow means not dragging a baby in an incubator with many lines and to the MR or CT scanners. The other, on that same note, the intraoperative use. Yeah, we use it intraoperatively for different indications, and that may have surgical impact. And we have now new indications that I'll share tomorrow with you on about how to use that intraoperatively. That's a plus. Interventional is in the suite that you're doing interventionally, or the intralymphatic, which are complex procedures, you're doing it right there and then on the table. So these are major impact on the pediatric population. And lastly, I want to mention also there are new advancements, because we were discussing about pregnancy. We've been using, at our institution, there has been a lot of research in trying to develop an artificial womb to have a place for premature fetuses to try to extend their time in the intrauterine environment. This has been done in animal models, and where we have used contrast agents to monitor, for instance, the brain perfusion and other indications, or the lung maturation. And now this is going to come very soon in patients, in real premature fetuses. And this artificial womb, you will not be able to move around in CT or MR, and you will be able to do the ultrasound studies right at the bedside. So these are really significant developments for the future, and we have not really fully explored all the potentials, and this is something we grow together with and learn over the years.
Yeah. I think we have to give great kudos to your department for coming up with ways of improving the use of these agents. The one thing that I find really interesting is your musical portable potty for VCUs to relax the child and actually make it a fun experience, as opposed to I think these things I think are really helpful.
Yeah,
and,
I mean, that's workflow.
It's workflow, yeah.
Yeah, if you do it on a fluoroscopy suite with a fluoroscopy, you can't use all these gadgets. But if you do it on ultrasound, you can use a potty or a musical potty that you can put it on the table, and the child can sit and pee while the music plays, and you can scan the child from the back. You can scan the kidneys, you can scan the bladder. So it creates a more patient and family friendly environment. You have these options with.
But many of those kids are going to come back for repeat exams.
Yes.
So I would think giving them a positive experience by the musical potty would make it much better for them to come back the second time, as opposed to doing it under fluoroscopy.
Yeah, so true. And for instance, the reflux studies, if there is a reflux present, the usual pattern is to do an annual reflux examination. So they might be coming a number of times.
Radiation savings.
Yeah, radiation is saving. But I think the workflow, I feel it's important, because even with the fluoroscopy scanner, now we are having newer machines that have very little radiation. But still, of course, you save radiation, but the workflow is even much more important, and the patient-family experience is much more important.
So we've talked about the different safety aspects, the risk-benefit ratios, and how we prepare for these. Just very similar for radiologists, CT and MR. We really don't do anything different for these ultrasound contrast agents. But I think recently there's been some issues coming up that in cardiology, only in the United States, that there have been some serious adverse events that have led to deaths. We don't see this in populations in Europe or China, where there's a large number of patients being done, and we don't see it in radiology. And again, I've looked through the radiology literature using any of the ultrasound contrast agents that have been available, and there are no deaths ever reported in radiology, but we've now seen deaths that occur in cardiology. Can we, I'm assuming we don't know why, but can we discuss this? And again, is the risk-benefit ratio such that we know what's going to happen, but we're more likely to have a better outcome for those patients but getting contrast than not getting contrast?
Yeah, I think absolutely. There's been some concerns that have been raised about reactions that have occurred in the United States, either leading to death or serious arrhythmias. There have been reports of ventricular tachycardia or other types of reactions. Again, these are very rare and infrequent, but they do happen, and they certainly have not occurred looking at the data from Europe and from China. And I don't think we really understand why that's the case. People have been using these agents for 20, 30 years, and somehow now we're having these sort of case reports come out of circumstances, but albeit rare, that ultimately result in either death or other concerns. And I think part of this is we have to be prepared as a group if that these events can occur. Some of these probably may be Kunis syndrome, people with preceding chest pain or other sort of symptoms that may indicate that there might be an underlying Kunis syndrome going on. And I think it's important that labs be prepared ahead of time so that they are able to deal with these circumstances in the rare circumstance where it hasn't. But it doesn't abrogate by any chance the need for use of these agents. We know both in the cardiology literature that it in multiple sectors of the cardiology literature that in fact these agents are associated with an improved mortality, and we understand why that might be the case. I mean, within cardiology, all the time we're identifying people who have regional wall motion abnormalities. We're better characterizing apical dysfunction. We see a lot of near-field clutter on ultrasound, and it's very difficult to sort of assess what's going on with the apex in many patients. And you can be fooled to think that you have a completely normal apex and you have somebody with either an apical thrombus, mass, hypertrophic cardiomyopathy, apical hypertrophy, and you can, non-compaction cardiomyopathy. You can really help delineate what's going on with the cardiac structure and in function in a way. In fact, Dr. Porter has done really some seminal work on looking at perfusion of the myocardium. And so not only are we able to give people information on regional wall motion abnormalities, but we're also able to give them the really granular information about what's going on at a really perfusion on a microscopic basis with the myocardium. And that's translated into benefits. We know from a paper that we published a couple years ago now that about 6.8% of people, 6.8% of echoes in the U.S. get contrast, about 20% of stress echocardiograms. If you look at those who got contrast after acute MI, patients who got a contrast after acute MI had a lower rate of cardiac catheterization and lower rate and actually lower cost in the sort of cumulative cost of care. And that's been shown in multiple studies that the cost, the downstream utilization is less because people make the certain diagnosis up front, and so the downstream utilization is significantly less. So in terms of why this is happening right now, I think the jury is still out, and there's lots of ongoing investigation about why that might be the case.
I think you have to really look at the substrate here. I know that Harold Bescher reported over 10 years ago already, some cases of acute coronary syndromes occurring in Europe that after a contrast administration. And so I think that it's not just a United States thing. I think it's a substrate thing. And I think it's, we're doing studies in patients that are being worked up for some form of chest pain, some form of heart failure, some form of underlying coronary condition. So in that particular patient population, I suspect that those patients are the ones that are most predisposed to progressing to the Kuna syndrome after having some type of anaphylactic reaction. So it's this perfect storm. We know this is extremely rare, of people dying after a contrast agent, but the sequence of events may be such that you have just the right substrate, in other words, some kind of underlying coronary disease, that the anaphylactic reaction perhaps precipitates this vasoconstriction that we see in ST elevation that we've seen described. But I do recall this being reported in Europe over 10 years ago. So although you may have
But deaths or just
well, they were near
deaths,
near
but-
deaths,
yeah.
so
And then that brings up, if were the patients at death, were they intervened more rapidly, that maybe they would have not died and had resuscitation
think that-
beforehand? Is that something we don't really have a good feel for the people that did have deaths, that they weren't treated appropriately? And like I said, I've only had one serious adverse event, but just giving saline has really was enough to bring the patient out of it. And I would assume if we didn't do anything, that this could have progressed to be something worse than what it was.
And I think Joy's point about 6.8%, isn't that a sad number? That we're still only using contrast at 6.8%. I know obesity isn't just in Nebraska, okay? It's throughout the country. We know it's an epidemic, right? And we know that the windows have become much more difficult over the years. We are grossly underutilizing ultrasound enhancing agents to detect and pick up these abnormalities that Joy pointed out, that we do day in and day out. We see this happening in our labs that are using it routinely. We really need to get the message out that it's much more dangerous not to use an ultrasound enhancing agent than to use it.
Yeah. And to that point, I just wanted to add that we've seen an increase in rates of suboptimal image quality over time. So that's not just a perception. We have data points to support that there's been a change in the patient population that we treat. And as we expand, in particular within echocardiography, as we expand our indications, as we use echo in a broader population, as the patients that come in are surviving longer, are more complex, are having more complex interventions done to them, we're really dealing with it with a much more challenging and difficult substrate. And so, the patients we see now need contrast perhaps more even than we even had before, and of course there was a huge need then too. So I think the point about the utilization is well taken. We really do need to get better.
Yeah, and I think from the radiology side, we're somewhat not happy that our influence of using ultrasound contrast to help patients has not been at a level we think is appropriate, that it's not spread to many more centers. My feeling is that anyone with a cancer deserves a contrast study. And if they can't get a CT or MR with contrast, they deserve an ultrasound contrast. And if they don't get it, that's really malpractice, because we're really not treating those patients, because these agents are approved. They're available, and we should be offering this to patients. It's not an expensive test, and this should be widely available. And if your center does not want to use it, you should have a center that you refer your patients to that can do this for staging. Because I think staging a patient with cancer without a contrast study is really not a good thing, and the patient deserves a contrast study.
Just one other point, which is that the couple of circumstances we've seen where deaths have occurred. This is not universal, but oftentimes their sonographers are practicing and administering contrast in a sort of a void. They don't have the support necessary or the training necessary or the code card available to be able to use. So if something does happen, then they're in a little bit of a lurch. And so I think it's really important that we have really robust standards for safety. This can happen. We know it's infrequent, but it can happen in circumstances. And we have to, as a society, be prepared in all of our laboratories and in all settings that we're using. We have to be able to be prepared just in case something should happen. And again, we hope in 90 9.999% of cases, that's not going to be the case. But in that very rare circumstance, that's where all that preparedness can really help, I think, drive the best outcomes for our patients.
So before we close and I give a summary statement, does anyone else want to add some more comments about the use of ultrasound contrast, why we should be doing this, and what we can do to maybe increase the utilization both in cardiology and radiology?
Well, I think the numbers have spoken for themselves, the huge volumes that each of us have done, and the extraordinary safety record that we have with all the ultrasound enhancing agents, and not just the testimonials, but the large databases now showing that we're getting a definite signal that we're doing a better job with the patient and caring for them in acute settings, that point to the fact that we need to really use it liberally and use it safely.
You know, it's an absolute conundrum to me. Richard, you and I have talked about this so often. I cannot believe why everybody doesn't do it and do so much of it. It's so beneficial, and I think from a radiology perspective, unfortunately, it's more labor intensive, and it's more time demanding. Not everybody works like you and I do, or we do this all day long. And so those are negative aspects inside the practice of radiology. I don't know how cardiology comes across in that regard, but there's no question that we need to improve the education of radiology residents so that when they come out of their training that they're able to do it. And the doctrine that said that this was postgraduate training to do this was wrong. I mean, it should be part of residency training. But I think it's tremendously beneficial, and that's our biggest challenge always is education of clinicians about what they should be doing on their patients.
I just also want to add, I mean, there are many stumbling blocks to try to introduce contrast ultrasound or a new modality. But we do really have to see the risk-benefit value of contrast ultrasound, and I strongly believe in children. It is really a very important modality that is so impactful. I feel it's the responsibility of those that do it to share knowledge with others. So I feel that education is important. We have to create an educational platform for others to learn, and if we don't do that, others cannot learn, and the modality will not spread. It's not just for the sake of spreading modality, but for the sake of making a positive impact on our pediatric patients. So all of us who do these studies need to create a forum where we can teach others in various different ways, be it in person, virtually, or otherwise. And that way, gradually, these modalities will spread. It may not, but one thing I can share with you, having practiced 20 years in Germany and tried to implement contrast ultrasound, the implementation was relatively widespread, but the speed was much, much slower. In the US, after the FDA approval 2016, it really caught like fire. Many pediatric places had these contrast ultrasound studies doing it, many more patients within a short time than it was done in Europe. So there is a potential that shows you that you can help others to be able to do these studies. So I think we have to keep on doing it, and others will catch up and also share their knowledge with other colleagues so that we will have this modality over time being available for many patients. In addition to that, we have also to find a way to teach our referring physicians. I think we are not as strong in that, so we have to make really a proactive approach to getting to our referring physicians so that we can teach them there is a new modality that you can refer to your patients, and that it really makes an impact. It really is really very positive to see how it can influence if the referring physician knows that this exam can make a difference. I can just give you an anecdotal story. I was at Texas Children's teaching as a visiting professor, giving a lecture on use of contrast ultrasound, and the radiologist sat next to the neonatologist. And I was just talking about the use of this modality in necrotizing enterocolitis in children. And I remember after the lecture, the neonatologist turns to the radiologist and said, well, I have a patient there in the ICU. Why don't we do it? And then the radiologist said, oh, okay, let's go and start doing it. That was the first time they were using intravenous contrast in children, you know? So because the referring physician was really impressed how it can make a difference, they wanted to use it right away. So I think teaching both the images, the pediatric radiologist and the referring physician.
This was at what institution?
At Texas Children's, yeah.
They didn't know about the use of it.
Yeah, they were using it intravesically, but they hadn't started using IV. But that day after the lecture, because the neonatologist was there, they started using that. So it was very positive experience.
And education.
Yeah, both the referring physician and the radiologist. So I think that's really a positive experience.
So I think at least within cardiology, we see it, and I hear very frequently a sort of a tired trope from sonographers that, you know, if you are not able to visualize the walls, then that's somehow a deficiency on your part as personally as a sonographer, and you need to work harder or better. And I think we need to move beyond that. You know, we know 10 to 20% of our patients walk in with insufficient images to really be able to get diagnostic quality information. I think if we look across fields, you would never dare in some circumstances in radiology to not give contrast. And so we really, and it would be sort of non-standard of care not to. And so within cardiology, somehow this approach has taken where we don't think of it as the default mechanism, but we have a tool at our disposal that's going to better help us take care of our patients. And yet we too little often reach for that tool to be able to use it. And so I think, you know, educating is one thing. There are workflow challenges that we encounter that we work through. The largest one of which is IVs. For our patients, require an IV, and if you're an outpatient, you require to have an IV placed. And so, you know, we've developed mechanisms to try to identify those patients ahead of time, have them come in, get their IV placed, and make that decision to give contrast at the point of care based on the quality of the images. There's also a lot of work being done through the International Contrast Ultrasound Society to be able to train sonographers at the outset in sonography school to be skilled on IVs, but also on contrast. We know that contrast in general is not taught at a lot of sonography institutions, and that's in part because the educators themselves were never taught in the first place. So if they don't know, they can't pass on the knowledge to the next group, and I think it becomes a self-fulfilling prophecy. So we need to get better as a society, we need to get better as a group, and I think some of these challenges are shared amongst radiology and cardiology, and some of them are unique to those individual disciplines, but I think as a group that we have a common problem, which is we're not using contrast enough, and we've already explained all the wonderful benefits of it. We know that the safety profile overall is very robust and has been robust for quite some time. And so I think as long as labs are prepared, labs are focused on the benefits and educating their sonographers and their groups, we should hopefully all do better in provision of care for our patients.
I think there's one point we haven't discussed. Think about the cost, how much money you have to spend for a single examination. In Europe, ultrasound costs only 1/3 in comparison to CT and 1/5 in comparison to MRI. So if the quality of the examination, for example for liver lesion, is similar, the insurance could save a lot of money with less risk.
And I think also when we look at a lot of institutions, it may be months to get an MR where ultrasound could be done the same day.
Yeah.
And having a situation where you have ultrasound contrast if indicated, so that the patient comes in for a screening liver for a hepatitis C patient and you find a new lesion, you just give the contrast at that setting, as opposed to telling them to come back 2 months later for an MR. Really speeds up their treatment as well as is much more cost effective. So let me just summarize what we've decided. I think we all agree that adverse events occur. They're very, very rare. The risk benefit is far greater to give the agents than not give the agents, and we all have situations where we made a huge impact on patient care by giving these agents. And that, I think, is really important. Education, I think, is really important for us, and ICUS has been doing a really good job in trying to train sonographers to start IVs to make life a little bit simpler. We've tried to push so that there's more education in at least the sonographer schools. We're struggling with trying to get it into radiology residency programs, but I think we're making a little bit of impact. But one thing that I think we've tried, but it has not been as fruitful as I would like, is that we need to go to organizations, like Casa said, that you go to the referring clinicians and let them know this is available and that their patients are going to suffer if they don't get an ultrasound contrast, and they go to the radiology or cardiology department and say, I want my patient to have an ultrasound contrast because they had a CT and it's indeterminate, and I want to know what it is. And I think Stephanie has done a lot of work showing that we often answer the questions, and I think the literature points out 85% of the time when MR and CT can't give you a definitive answer, 85% of the time CUS gives you the answer. And it really improves patient care, it expedites patient care. And again, I think in my situation, our urologists and nephrologists, because we've been doing this for so long, never order CT MR. They just automatically go to ultrasound contrast because they feel that we do a much better job than CT and MR. I think, again, going to some organizations, we need to let OB-GYN physicians know that ultrasound contrast is safe in pregnancy, and if they do have a patient with a problem, they need to find a place that they can send the patient to. As Stephanie said, she's got several cases where this made a huge impact in the patient. Even though they were pregnant, we were able to treat the disease. I mean, the patient had a nephrectomy during pregnancy and did fine. So again, letting OBs know that this is available and not sitting on those patients. I've tried to get the organizations involved with patients in renal failure to be knowledgeable about this and to notify patients that these agents are safe, they don't affect kidney function, and that they should demand, if they need a contrast study, that they can get an ultrasound contrast. And I think, again, if an institution doesn't want to do this, they should know a center that's nearby that will do it so they can refer those patients that deserve that. And again, I'd like to let the audience know that ICUS, the International Contrast Ultrasound Society, has a wonderful website with a lot of educational material, a lot of case studies, and a lot of information. And I would advise it's free to join ICUS. I really encourage everyone to join and look at all that information. And our newsletter comes out every 2 weeks and has new information on what's being done. And again, we hope to have a lot of hands-on sessions coming up. We kind of stopped those due to COVID, but we have many webinars that are given several times a year on certain topics. And again, I think if you would go to the ICUS website, you could see where these webinars are and where their conferences are to get education. So I want to thank the panelists for their comments and giving us their experience and their ideas of what they do and how they deal with the safety issues of ultrasound contrast. And again, I think we all agree that you need to be prepared. You need to have a crash cart. You need to know how to treat those agents. And in our practice, we see many, many more reactions with CT and MR than we do with ultrasound contrast. So again, from a radiology standpoint, the number of reactions is much, much less than we see with CT and MR. So if we're already prepared for those reactions in CT and MR, so there really is not that much difference in being prepared for the ultrasound contrast. So again, thank you for listening to us, and again, I really encourage you to go to the ICUS website and become a member. It's free. There's a lot of wonderful information and educational material, and hopefully we'll convince you all that you should be doing ultrasound contrast daily.